Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 253 of our pharmacotherapy series, which majors in osteomyelitis and septic arthritis. The first question reads, L.D.P., a 7-year-old girl, is unable to go to school today because of fever and worsening leg pain. Her upper left leg started to hurt 3 to 4 days ago, and last night she began limping. Her parents report no history of trauma to the area. Her past medical history is significant only for 2 episodes of otitis media at ages 2 and 5. In the pediatrician's office, maximal tenderness is localized over the left distal femur without knee joint effusion. No signs of swelling, warmth, or trauma are seen. Her white blood cell (WBC) count is 8,000 per microliter with a normal WBC differential. Plain radiographic studies of the left leg are normal, but the erythrocyte sedimentation rate, abbreviated as ESR, is 58 mm per hour. The normal value should be equal to or less than 30 mm per hour. 2 blood samples are obtained for culture, and L.D.P. is sent home with directions for bed rest and use of acetaminophen as needed for fever. 2 days later, she is admitted to the hospital with severe pain and tenderness in her left leg and a fever of 38.8 degrees Celsius. The blood cultures obtained 2 days ago are positive for Staphylococcus aureus with susceptibilities still pending. C-reactive protein (CRP) is 14 mg per deciliter. The normal value should be less than 2 mg per deciliter. Another plain radiographic study is normal, but a magnetic resonance imaging (MRI) scan reveals inflammation in her left distal femur. What findings in L.D.P. are consistent with hematogenous osteomyelitis? L.D.P. displays the usual signs and symptoms of acute hematogenous osteomyelitis in children. She is a previously healthy child who experienced acute localized pain and tenderness of the left distal femur, abrupt onset of high fever, and an elevated ESR and CRP. Her plain radiographic studies were normal on 2 occasions, however, destructive changes to bone often do not appear on plain radiographs for at least 10 to 14 days after onset of infection. Hence, a normal plain film does not rule out acute osteomyelitis if obtained within the first 2 weeks of infection. Diagnosis includes radionuclide imaging, e.g. bone scans, computed tomography (CT), or MRI. MRI is more sensitive than CT for the assessment of soft tissue and detecting early bone marrow edema. However, it often requires sedation for children. The sensitivity of bone scan detection of osteomyelitis has been lowest when the infection was caused by community-associated MRSA, abbreviated as CAMRSA. L.D.P's MRI scan on hospitalization detected inflammation in the left distal femur. Although L.D.P. did not have a bone biopsy sent for culture, her clinical picture, a positive MRI scan, and blood cultures positive for Staphylococcus aureus established the diagnosis of osteomyelitis. The specific event that caused bacteremia with dissemination to bone is unknown, as is often the case in children.
Laboratory tests that should be routinely obtained in every child suspected of having osteomyelitis include a complete blood count (CBC), ESR, and serum CRP. Although these tests are not specific for the diagnosis of osteomyelitis, they help confirm the clinical diagnosis. An increased WBC count is consistent with osteomyelitis, but leukocytosis is absent in many children with osteomyelitis at the initial examination. Thus, L.D.P's WBC count of 8,000 per microliter is not unusual. In adults, leukocytosis is more common in an acute infection rather than with recurrent or chronic disease. Both ESR and CRP are nonspecific markers of systemic inflammation when elevated. Predisposing factors for hematogenous osteomyelitis include any risk factors for bacteremia, e.g., indwelling catheters such as hemodialysis shunts and chronic central venous catheters. Other risk factors that can potentially lead to bacteremia and subsequently hematogenous osteomyelitis include IV drug use and a distant focus of infection in the gastrointestinal or urinary tract. None of these factors exist in L.D.P. in children such as L.D.P. who have no history of trauma, fractures, or penetrating injury. The most common cause of acute hematogenous osteomyelitis is Staphylococcus aureus, and the possibility of CAMRSA must be considered.
The next question reads, what additional patient and diagnostic information should be obtained before L.D.P. receives her first dose of antibiotics?
Before L.D.P. receives antibiotic therapy, she should be assessed for drug allergies, especially penicillin allergy. Patient interviews, discussions with her parents, and a comprehensive review of her medical record are necessary, especially with a history of allergy. Details of an allergic reaction, including symptoms, onset of the reaction, probable causative agent, treatment, and exposure to related antimicrobials should be evaluated. Cultures of blood and bone aspirate material optimally identify the pathogen and must be part of the initial workup prior to the start of antibiotics. Cultures taken after antibiotics have been initiated are often negative. Positive blood cultures are seen in 33% to 50% of pediatric bone and joint infections. In L.D.P's case, the positive blood culture and MRI establish the diagnosis of osteomyelitis. If the blood cultures had been negative, however, a bone aspirate would be recommended to identify the pathogen. Once material has been obtained for culture, empiric antibiotic therapy should start as soon as possible.
The next question reads, L.D.P. has no history of drug allergies. She took amoxicillin for the previous episodes of acute otitis media without incident. What empiric antibiotic or antibiotics should be started? What is the relevance of bone concentrations or protein binding of antibiotics in the selection of therapy for osteomyelitis? The chosen agent should be administered IV at high doses to optimize drug concentration in infected bone. Treatment should be initiated as soon as possible to improve the chances for complete eradication of infection and to avoid the need for surgery. Thus, empiric antibiotic therapy is often administered while bacterial cultures are pending or before antibiotic susceptibility results are known. Although cultures are pending or with negative cultures, the age of the child can predict the likely pathogen and guide empiric antibiotic selection. For example, Staphylococcus aureus and Streptococcus species are commonly responsible for osteomyelitis in the neonate. Shigella kingi, a facultatively anaerobic, gram-negative hemolytic bacillus, is being detected with increasing frequency in children under 3 years of age, especially in the day care setting. Summarizes the common causative organisms of acute hematogenous osteomyelitis in children and recommended drugs and doses for treatment. Considering the epidemiology of L.D.P's infection and the blood cultures, she should be treated for Staphylococcus aureus osteomyelitis. In both children and adults, the number of acute osteomyelitis cases caused by MRSA continues to increase. Empiric IV vancomycin should be administered pending susceptibility results. Alternative empiric therapy for L.D.P with MRSA coverage includes daptomycin or linezolid. Due to limited clinical experience, these two agents should be reserved for vancomycin-intolerant cases. Clindamycin is not an option for L.D.P, but may be used empirically for stable patients without bacteremia or intravascular infection. The importance of antibiotic bone concentration when treating osteomyelitis is unclear, and bone concentrations do not always predict outcome of therapy. Theoretically, protein binding could influence clinical efficacy because free drug is thought to diffuse from plasma into bone tissue and protein-bound drug does not. However, cefazolin for sensitive gram-positive cocci and ceftriaxone for sensitive gram-negative rods and streptococci, both highly protein-bound drugs, are well-established treatments for osteomyelitis when appropriate doses and duration are used. Therefore, antibiotic bone concentrations and protein binding of antibiotics in appropriate doses are not significant factors in the selection of appropriate therapy for osteomyelitis. The next question reads, the Staphylococcus aureus grown from L.D.P's blood culture is methicillin sensitive. Considering these results, what is the optimal antibiotic regimen? Would other antibiotics given less frequently also be adequate?
L.D.P is not allergic to penicillin. Although vancomycin is active against MSSA, it is inferior to beta-lactams. Thus, beta-lactam-based therapy should be used for susceptible organisms. De-escalating from vancomycin to oxacillin, or nafcillin, at 150 mg per kilogram per day every 6 hours is appropriate. Nafcillin and oxacillin are therapeutically equivalent and are given in similar doses. Therefore, selection typically depends on hospital formulary considerations. Her prior exposure to amoxicillin is irrelevant except to establish the absence of a penicillin allergy. Continuing to treat L.D.P with IV oxacillin, or nafcillin every 6 hours follows treatment recommendations for MSSA osteomyelitis. Antistaphylococcal penicillins are effective therapy with appropriate doses and duration. Changing L.D.P to cefazolin would allow slightly less frequent dosing, every 8 hours, a potential advantage for home treatment. Vancomycin use should be discouraged in L.D.P's case because cultures revealed a methicillin-sensitive organism, and vancomycin is more likely to be associated with treatment failure. In the absence of susceptibility results or of methicillin resistance, IV vancomycin would be required for the duration of therapy. Although the logistics of outpatient therapy in L.D.P are being investigated, she should remain on oxacillin while in the hospital.
The next question reads, both of L.D.P's parents are employed, and their work schedules prevent them from leaving their jobs to transport her to an outpatient antibiotic treatment center. Is L.D.P a candidate for outpatient IV antibiotic therapy at home, or is oral antibiotic treatment an option? Must L.D.P remain in the hospital to receive her oxacillin? Initially, all patients should receive IV antibiotics because early, aggressive therapy offers the best chance to cure the infection. L.D.P, however, does not necessarily need to stay in the hospital for the duration of therapy. A peripherally inserted central catheter, abbreviated as PICC, can be placed, and antibiotics can be administered. The decision to use home IV antibiotic administration must be decided in concert with L.D.P's parents. If L.D.P's parents do not have the resources or are unwilling to oversee IV treatment at home, L.D.P should remain hospitalized for a minimum of 1 week to assess the efficacy of IV treatment. Transition to oral therapy should be considered at discharge due to the frequency of PICC line complications and the cost and inconvenience of several weeks of IV therapy at home. L.D.P can complete most of her treatment with oral antibiotics, but oral therapy should not be given until the effectiveness of IV therapy can be assessed. Children with uncomplicated acute osteomyelitis are candidates for oral therapy when clinically improved, and the CRP has normalized, typically between 3 and 7 days. Total duration of antibiotic therapy should be 3 to 4 weeks, however, current IDSA guidelines recommend 4 to 6 weeks of therapy for children with MRSA osteomyelitis. Neonatal cases warrant 4 weeks of IV antibiotics. The next question reads, after 1 week of IV nafcillin, L.D.P is afebrile and reports that the pain and tenderness in her left leg are much improved. Her ESR is 40 mm per hour, and CRP is 6 mg per deciliter. The plan is to switch L.D.P to oral antibiotics to complete a 4-week course of therapy at home. What would be an appropriate oral antibiotic regimen for L.D.P? How often should she return to the clinic for evaluation? Again, oral antibiotics are only appropriate if a clear clinical response has occurred within the first week of IV therapy, the patient's parents are aware of the vital importance of compliance, and the patient can swallow and tolerate oral therapy. Assuming her parents agree to supervise treatment outside of the hospital, L.D.P is a candidate for oral therapy. She has responded promptly to the IV therapy. Her symptoms have improved, and the ESR and CRP are trending downward. Oral therapy will be effective only if L.D.P consistently takes her medications, therefore, assurances must be in place to facilitate compliance. L.D.P's parents have made arrangements with her teacher to help her take her oral antibiotic during the day. L.D.P can complete her 4-week course of antibiotics with oral cephalexin capsules or suspension, which is more palatable, and is usually better tolerated than dicloxacillin suspension. Cephalexin should begin at 37.5 mg per kilogram per dose every 6 hours. Weekly follow-up is necessary to monitor compliance and clinical response to therapy. Parenteral therapy should be reinitiated, and re-evaluation is warranted if L.D.P's compliance is not optimal, symptoms recur, or ESR or CRP increases. The next question reads, MKU, a 30-year-old man, suffered an open left femur fracture 3 weeks ago in a motorcycle accident. His fracture was set by open reduction and internal fixation. MKU had received prophylactic piperacillin tazobactam for soft tissue coverage of the open fracture for 72 hours after hospitalization. His postoperative course was unremarkable until yesterday when he experienced left leg pain and spontaneous drainage from the surgical wound. On presentation, his left thigh is tender, warm, swollen, and erythematous, but he is afebrile. Laboratory data, including WBC count, serum creatinine, and blood urea nitrogen, are normal, but the ESR is 38 mm per hour and CRP is 8 mg per deciliter. Plain bone films and bone MRI show inflammation and non-healing of the femur fracture. So my question to you is, what findings in MKU are characteristic of secondary osteomyelitis? Few of the systemic signs and symptoms usually associated with acute osteomyelitis are seen in secondary osteomyelitis. The most common subjective complaint in acute contiguous osteomyelitis is pain in the area of infection, localized tenderness, swelling, erythema, and drainage. Considering several weeks might pass before the patient becomes symptomatic, radiographic studies at the time of diagnosis might reveal abnormalities consistent with bone deterioration. MKU's case is consistent with osteomyelitis secondary to a contiguous focus of infection. Infection likely is at the site of surgical repair of the left femur fracture. MKU's localized symptoms, along with the absence of fever and leukocytosis, are characteristic of secondary osteomyelitis. In these cases, bone becomes infected from an exogenous source or through spread of an infection from adjacent tissue to bone. Infection can result from any trauma with or without subsequent orthopedic procedure to fix a bone fracture. The bones most commonly involved are the tibia, fibula, femur, and hip. Unlike hematogenous osteomyelitis, which occurs mostly in children, acute contiguous infection occurs more often in adults. This finding is explained by the higher incidence of precipitating factors within this age group, such as hip fractures, orthopedic procedures, oral cancers, sternotomy incisions for cardiac surgery, craniotomies, and trauma. Other conditions potentially associated with secondary osteomyelitis include gunshot wounds, punctures, or soft tissue infections. The next question reads, what organisms are most likely causing infection in MKU? Whereas hematogenous osteomyelitis usually involves a single pathogen, polymicrobial infection is common in contiguous spread osteomyelitis. Although Staphylococcus aureus is the most common pathogen, it is often part of a mixed infection. Other common pathogens include Pseudomonas, Proteus, Streptococcus, and Klebsiella species, Escherichia coli, and Staphylococcus epidermidis. Most cases of osteomyelitis involving the mandible, pelvis, and small bones, e.g., those of the hands and feet, are caused by gram-negative organisms. Pseudomonas often is isolated from infections after puncture wounds of the foot. Anaerobes also are associated with contiguous spread osteomyelitis, and most commonly isolated are Bacteroides species and anaerobic cocci. Possible predisposing factors include previous fractures or injuries resulting from human bites. Adjacent soft tissue infections can also lead to anaerobic bone infections, as in the case of sacral osteomyelitis secondary to severe decubitus ulcers. To identify the true pathogen or pathogens, MKU should have surgical re-evaluation and a biopsy of involved bone at the probable site of infection. Bone films and the MRI scan will help localize the possible infectious process to direct the surgical biopsy. The next question reads, MKU returns to the operating room for surgical exploration, and bone tissue is obtained for culture. He has no drug allergies and weighs 90 kg. The initial postoperative antibiotic order is for vancomycin, 1 gram IV every 12 hours. Is this adequate antibiotic treatment for MKU? MKU has had surgery to obtain bone material for culture because cultures of adjacent wound or sinus tract material are not always predictive of the bacteria actually infecting the bone. Broad empiric antibiotic coverage is necessary because S. aureus and polymicrobial gram-negative aerobic bacilli most likely are causing this infection. MKU has been started on vancomycin for possible MRSA infection while awaiting results of bone tissue cultures. Many clinicians target goal trough concentrations between 15 and 20 micrograms per milliliter for osteomyelitis. Given his normal renal function and weight, MKU will likely require at least 1.5 grams IV every 12 hours of vancomycin, 15 mg per kilogram per dose. to cover possible pathogenic gram-negative aerobic bacilli, a third or fourth generation cephalosporin, cefotaxime, ceftriaxone, ceftazidime, or cefepime, or a quinolone, ciprofloxacin, or levofloxacin could be added. The choice of agent should, in part, be based on local susceptibility patterns. In locations in which quinolone gram-negative resistance approaches 30%, these agents have limited utility. Anaerobic coverage should be initiated if an anaerobe is cultured from bone or anaerobes are suspected. Vancomycin has activity against gram-positive anaerobes, but not against the gram-negative anaerobe, Bacteroides fragilis. If Bacteroides fragilis is cultured from bone, additional therapy with metronidazole is indicated. Alternatively, combined, broad-spectrum aerobic, including Pseudomonas, and anaerobic gram-negative coverage could be provided by a beta-lactam, beta-lactamase inhibitor combination therapy with piperacillin, tazobactam or a carbapenem. Although cultures are pending, MKU's antibiotic regimen is changed to vancomycin 1.5 grams IV every 12 hours and cefepime 2 grams IV every 8 hours. The next question reads, the bone biopsy from MKU grows MRSA that is sensitive to vancomycin, linezolid, and trimethoprim, sulfamethoxazole. His leg pain is no worse than it was 2 days ago, and he remains afebrile. How should MKU now be treated? Is he a candidate for oral therapy? Because no gram-negative organisms grew on culture, cefepime may be discontinued. Therapy should be directed against the MRSA. Thus, it is justified to continue treating MKU with vancomycin 1.5 grams IV every 12 hours, as long as he is monitored closely. Following his symptoms, a vancomycin trough level between 15 and 20 mg per liter, weekly ESR or CRP concentrations, complete blood count, and metabolic panel. Vancomycin can be administered at home with the appropriate home health care. Studies have shown that oral antibiotics can achieve adequate concentrations in bone. Based on clinical improvement and provider preference, MKU can be transitioned to oral linezolid, dosed at 600 mg twice daily, or trimethoprim sulfamethoxazole TMP-SMX, dosed at 4 mg per kilogram per dose of the TMP component twice daily, in combination with rifampin, dosed at 600 mg once daily, for a minimum of 8 total weeks of therapy. He should be followed closely for at least 2 years to detect recurrent infection. The next question reads, C.M.S., a 55-year-old woman, presents to the diabetes clinic with an ulcer 2 cm wide by 1 cm deep on the left lateral aspect of her foot that she first noted a month ago. Her primary care physician had prescribed a 2-week course of ciprofloxacin and gave her instructions for regular wound care. A few days before her clinic visit, the callus surrounding the ulcer cracked open and a small piece of bone protruded from the wound. She reports mild swelling and redness but denies any pain, fever, or chills. Her past medical history includes type 2 diabetes mellitus, hypertension, peripheral neuropathy, and chronic kidney disease requiring hemodialysis 3 times a week. Laboratory findings include a WBC of 5,200 per microliter with normal differential, BUN of 56 mg per deciliter, serum creatinine of 5.6 mg per deciliter, fasting blood glucose 240 mg per deciliter, hemoglobin A1C of 12.4%, and ESR of 45 mm per hour. So my question to you is, what findings in C.M.S. are consistent with osteomyelitis secondary to vascular insufficiency? C.M.S. has chronic lower extremity vascular insufficiency as a result of type 2 diabetes mellitus. Patients with impaired blood flow may develop osteomyelitis in the toes or small bones of the feet. Infection often first presents as cellulitis, as in C.M.'s case, progressing to deep ulcers and finally to the underlying bone. Similar to contiguous spread osteomyelitis, systemic signs of infection, e.g., fever and leukocytosis, are often absent in patients who experience bone infection secondary to vascular insufficiency. Local symptoms such as pain, swelling, and erythema usually predominate, but there are no specific clinical findings. C.M.S. may have a bone infection under the chronic, cutaneous ulcer on the bottom of her left great toe. Because of peripheral neuropathy, the skin lesion may not be painful, and poor blood supply to the site likely contributed to the development of a chronic infection and possibly secondary osteomyelitis. The true depth of an ulcer is not always clinically apparent, so careful physical examination and evaluation of patient risk factors are essential for diagnosis. Infection is suggested by her elevated ESR, fasting glucose, which is consistent with infection, and HbA1c, indicating uncontrolled diabetes. In addition, diabetic foot ulcers with an area larger than 2 cm² or that penetrate to bone are often predictive for underlying osteomyelitis. The next question reads, C.M.S. is admitted into the hospital for diagnostic workup, wound care, and antibiotics. Plain films show destruction of the distal left fifth metatarsal with bony changes consistent with osteomyelitis. Her wound is debrided, and material obtained from a bone biopsy is sent to the microbiology laboratory for cultures. She has no drug allergies and is started on vancomycin 1 gram IV every 12 hours, and oral ciprofloxacin, dosed at 750 mg every 12 hours. Is this appropriate initial, empiric therapy? In many cases of osteomyelitis associated with vascular insufficiency, multiple pathogens can be cultured from surgical specimens or the wound. The most commonly isolated pathogen is Staphylococcus aureus, however, gram-negative and anaerobic bacteria are also often recovered. The bacteria isolated from a wound or soft tissue culture may not correlate with bacteria found in a concomitant bone biopsy. Therefore, empiric antibiotic therapy for osteomyelitis associated with vascular insufficiency should be active against both gram-positive and gram-negative aerobic bacteria and possibly anaerobes. No specific regimens have demonstrated superiority, so a broad-spectrum empiric regimen can be chosen based on local sensitivity patterns. An anti-pseudomonal beta-lactam, such as ceftazidime or cefepime, or quinolone, such as ciprofloxacin or levofloxacin, for gram-negative coverage is frequently used as an empiric regimen. If anaerobic bacteria are believed to be clinically involved, e.g., foul-smelling wound, metronidazole should be added to the regimen. Alternatively, an anti-pseudomonal beta-lactam, beta-lactamase inhibitor combination, such as piperacillin tazobactam, can be used. C.M.S. has risk factors for MRSA and resistant gram-negative bacilli because of her diabetes, hemodialysis, and recent course of antibiotics. The initial regimen of vancomycin and ciprofloxacin for C.M.S. is not optimal for several reasons. Because of her recent, prolonged ciprofloxacin exposure, a quinolone-resistant organism may be responsible for infection, and a beta-lactam-based antibiotic regimen would be more appropriate. Secondly, IV antibiotics should be used during initial treatment. Lastly, C.M.S. is dialysis-dependent, and the antibiotic regimen selected should be dose-adjusted according to her renal function. A more appropriate empiric regimen for C.M.S. would be vancomycin intermittently dosed based on serum drug concentrations and her dialysis regimen, and cefepime 1 gram IV every 24 hours with the dose administered after dialysis on dialysis days. Further antibiotic refinement should occur after the results of the deep wound swab culture are available. The optimal duration of IV therapy for diabetic foot osteomyelitis is patient-dependent, and some patients may require longer-term, oral suppressive therapy. The overall duration of antibiotic treatment can range from 6 weeks to many months depending on the degree of surgical debridement and the healing rate of the ulcer. Oral linezolid, dosed at 600 mg every 12 hours, has been used to treat MRSA osteomyelitis in diabetic patients, although long-term therapy can be associated with hematologic and neuropathic adverse effects. C.M.S. should be made aware that osteomyelitis associated with diabetic foot ulcers is difficult to treat. Despite adequate surgical debridement of the infection followed by appropriate treatment with long-term IV and oral antibiotic therapy, cure rates are low. Even minor amputations, 1 or 2 toes, are unsuccessful in eradicating infection. Radical surgical approaches, such as transmetatarsal, below the knee, or above the knee amputations, often are necessary to cure these infections. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 254.